Hello, everybody, and welcome to KRS421, first lecture, Injury Evaluation Process. So this starts with Chapter 1. So the injury evaluation process is important for a lot of reasons, especially when we think about the care of our patients across an entire team of healthcare providers, regardless of your profession, whether you're in one of the clinical professions like athletic training, physical or occupational therapy, or more of the medical models of MDs, DOs, EMTs, nurses, physician assistants. The evaluation process is very similar, it's very systematic, and being able to communicate in terms of total patient care, it's all interrelated and important to really consider those factors. So anytime we approach an injury, we're working through a differential diagnosis. If you've never heard of that term before, the words are basically coming up with the single thing that's wrong with a patient, because we start with a list of a lot of different possibilities. So for example, if someone says my shoulder hurts, of course, if we remember the anatomy of the shoulders, there's a lot of different things that could be creating pain or dysfunction in a patient. And so from the list of suspects we have, we can create an evaluation process to either rule things in or rule them out, right? So if they're pain generators or if they're normal. And so if we think about Ann Kuhl's algorithm here, if we kind of zoom in on that, Ann Kuhl's is a well-renowned shoulder researcher. If you're interested in learning more about the shoulder, I definitely recommend reading her line of literature. And so when people complain of pain and symptoms in the shoulder, like how do we decide between all these pathologies you see here at the bottom? So rotator cuff versus instability versus bicep, all those things can create shoulder pain. So you have to use this kind of flow chart idea of working through special tests and the evaluation process to come to a decision of like, I think it's this one thing. That way you can create a good plan of care to make sure that the patient actually recovers. Okay, so if we think about the different types of evaluation, the one we'll kind of talk about the least is triage. So that got its name from military settings or acute care settings where you have multiple patients who are injured simultaneously, and you have to decide who to treat, what kind of treatment they get, and it's based off a number of factors. We won't use that one too often. Most of the time we're talking about our two types of clinical evaluations, or on-field, like the acute setting. The initial evaluation, so the first time you're seeing the patient, is very important for establishing, what's their baseline symptoms and what kind of conditions they're going through currently. And then, of course, the clinical one, which you guys have probably experienced if you shadowed in the athletic training or physical therapy setting. The clinical evaluation is a much more detailed, lengthy. It could be 60 or 90 minutes long compared to like an on-field or an acute one where it might be 30 seconds, 2 minutes, 5 minutes, because you're trying to make different decisions, right? So we have an acute one and then we have a clinical one. And then within the clinical realm, we also have follow-up notes or progress notes. So let's say your patient had rotator cuff surgery, and they've been in physical therapy for 8 visits or a couple weeks. The orthopedic surgeon might want an update on their range of motion or their strength or some type of other evaluation technique. Right? So those follow-up evaluations are always a lot shorter because you already know what's wrong with the person, and so your evaluation and the information you're reporting is much more brief. Okay, so for you young clinicians, everything should be based on the idea of solving the problem, right? That's the main goal of our differential diagnosis. And as long as you understand what healthy is, that's a good starting point. This class, and if you go off to grad school for one of the clinical degrees, they'll teach you more about abnormal tissues and how to evaluate. But remember, you always have to know what's normal. That's why the first class you ever study is anatomy, right? You always learn what are the bones, what are the ligaments, what are the muscles. You have to learn what those things are normally, then you can understand what they're like when they're pathological. So if you understand a normal range of motion or normal strength or how to test those to establish like baseline measures, then the second part of the equation, understanding what's weakened, what's tight, what's injured, what's causing pain, what's clicking or catching inside of a joint, like understanding that abnormal is the key for the second phase, right? So step one is to evaluate the patient. Step two is to come up with the plan to make them better, right? So if you can't come up with a good evaluation or you don't figure out what's wrong, then you're not going to be able to come up with a treatment plan. Okay, the textbook does a good job of kind of describing regional interdependence, or the relationship between, the SC joint and the AC joint, or the scapulothoracic articulation and the shoulder. All those things are linked together. Typically we refer to that as the kinetic chain. But if we think about this example of when you normally throw a ball, you go up into flexion, abduction, external rotation, and then you reverse that coming into elbow extension, glenohumeral extension, and internal rotation. And that's, a very common throwing mechanism, and we understand how those things are linked together, but we can highlight it in this second part. Like now imagine trying to throw a ball with your elbow completely locked out in full extension, right? So now to generate that same amount of force, you're gonna have to use your glenohumeral joint like a windmill and kind of sling it in more of a circumduction fashion. And so like that example should help kind of highlight, when one joint decreases its motion, you have to pick up the slack at other joints or other muscles to achieve the same goal, like to throw the ball. That's the goal. So if you're swimming or lifting weights or whatever upper extremity activity you're doing, spiking a volleyball, throwing a javelin, if we have small changes to one muscle, a ligament, a joint, then what is the compensation pattern going to be? And is that something that could create injury? So we talked a little bit about, how the scapulothoracic joint is kind of related to the glenohumeral joint. And when we talk about that in chapter 15, the shoulder, these ideas will be kind of teased out a little bit more. And so this is just to get the ball rolling. So if we think about someone who has to do a kinetic chain activity of the upper extremity, like let's say you're doing this Y balance test and you're trying to reach under and over across the body. Obviously, the right arm has to stabilize, the left has to rotate, you get lumbar rotation. And so all the joints are linked together in one fashion or another. Okay, during the evaluation process, we always have to start with what's normal. And so sometimes we rely on the opposite limb or the contralateral limb, especially if it's uninjured, to give us key information about what this patient is like normal. So when we talk about baseline measures, of course, they can demonstrate the mechanism of injury or the thing that's causing the pain on the uninjured side, because you don't want to cause your patient more pain than necessary. So if they have like a rotator cuff injury, you're not going to just start in with like everything rotator cuff, because then that could increase their symptoms and make the evaluation a little bit more tricky. So everything we can do on the contralateral uninjured side, we try to do, because that tells us good information. Okay, so bilaterally, right, on both sides, injured and uninjured, we always have to assess for different characteristics of the tissues, right? So we'll talk about palpation, feeling the superficial structures with our fingers. So things we're looking for are guarding. So that's usually when muscles are tensing up, any type of swelling or effusion. So that's increase in the volume of the tissues, fluid building up. Then of course, joint function. So we'll talk about active, passive, and resisted ranges of motion, muscle strength. And then stability comes from the joint capsule and the ligaments. So when we're using special tests, we can assess bilaterally to get a good assessment. Especially when we think about the upper extremity, we get a lot more limb dominance, right? So your dominant limb, like if you're right-handed, we'd expect that side to be a lot stronger. It's usually 10%, like that's the number we're looking for. Okay. So one of the goals with the evaluation process is that we're always being systematic. This does a few things. So number one, it helps you not to forget anything, especially when you're a young clinician just starting out. It helps you do things in a stepwise progression so you don't forget anything. And then the other part of it is really to think about all the things that could be wrong with the person. And then you go through them in the least amount of damage you can recreate, or the least amount of pain. You always start with that first. So the history, like asking them questions, is going to cause the least amount of pain. But doing resisted range of motion or special testing of the injured area, those have the potential to cause a lot of pain. So we do them at the end. So regardless if you use a soap note, hops, we use those terms kind of interchangeably when we talk about a note that we're writing. Depending on your current level of experience, you might have never written a soap note or a hops or written out a note before, or you may have seen or talked to clinicians who have used them. And basically they're the exact same, right? So the history is mainly subjective information. Remember, things that are subjective is the patient's opinion. So, where does it hurt? How much does it hurt? And then things we see are the observation. And we start to get objective information, so you can see, a range of motion, or you can see swelling. Those are things that you quantify, right? Things are objective. And then our palpation, evaluative, and special tests kind of fall under the assessment umbrella, and then the plan. So for our textbook and the purpose of this class, we'll use this HOPES or HOPS, however you want to pronounce it. That's fine with me. Just recognize that, a lot of clinicians use soap notes, or they talk about soap notes, and it's essentially the same. It's just things are split up and divided differently. Okay, so if we start with the history, of course, it's going to be a series of Q&A. So you ask the patient questions and they give you a response. So especially because a lot of it could be subjective, you have to view the patient within the lens of like who they are. So if you don't know them personally, you really have to be careful, because 10 out of 10 pain is very different for different kinds of patients. I remember in the same week I treated a 15-year-old volleyball athlete who'd never been injured. They jumped up at the net, they came down, they sprained their ankle, and they were like crying, and it was 10 out of 10 pain, and they thought their world was ending because they'd never been hurt before, and then they were fine a few minutes later, and they were back in the game the same day. Versus, like, I remember I had a 32-year-old Marine who had an acute traumatic knee injury, severe pain, and he was like, "Oh no, I'm fine." And you can see his face, he's fighting back the pain. So if he says, his knee hurts and it's a 5 out of 10 versus, something that's going to require surgery for that patient, compared to like a 15-year-old who's like totally fine, that kind of intrinsic description of pain is very subjective. So you got to be careful with that. And that just comes with experience, We always ask open-ended questions. So when you're talking to your patient, a good example of an open-ended question is, "Tell me what happened." So that gives the patient a chance to explain things, versus if you say, "Did you hurt your shoulder?" They can only answer yes or no. So that's an example of a closed-ended question. So closed-ended, they can only answer yes or no, and those aren't good because you're going to have to ask a ton of questions. So we tend to only ask open-ended questions so that the patient can elaborate. Okay, and remember, the goal is you're trying to figure out what their symptoms are. So that's the things they tell you. Remember, the difference between a sign and a symptom is a sign is something you could see, a symptom is something the patient has to tell you. And we kind of lump those together in our signs and symptoms. So that's S/S. So if we ever use that abbreviation, S/S, we're talking about the signs and symptoms. Okay, and remember, we're trying to come up with our problem-solving nature, right? So each question should be progressive based on the answer they provide, where you can like dive a little deeper if they don't fully explain. So one of the main goals early on is to establish the MOI, or the mechanism of the injury. Of course, I'm sure you guys have heard these terms before: acute, chronic, or insidious. So soccer player jumps up to head the ball, he falls down, lands on an outstretched hand, and he feels pain in his AC joint. Right, so that's an example of our acute mechanism. Chronic would be a swimmer, has been training since they were 5, their shoulder starts to hurt, they haven't changed anything recently, and they don't know why. right? So chronic onset. And in that, I kind of also describe something that's insidious, and that's where they have no idea where it came from, right? So insidious means pain that's coming from an unknown source. When we think about the important sounds or sensation the patient's describing, it's very dependent upon the area between the upper and lower extremity. So if we think about the upper extremity, when someone says, oh, my shoulder clicks or cracks, 9 times out of 10, I've found that most of people's snapping, clicking, catching is the AC joint, which is, not that big of a deal as long as it's not painful. Things that we would worry more about, snapping, catching, clicking deeper inside of the joint, so something that could be the labrum, anything that's painful. So sounds can be a tricky one, especially when you get reverberation, like so if it's a sound that bounces around inside of a joint. So popping and snapping, that's kind of like, okay, you gotta really figure out what's going on. The feeling of shifting or giving out or instability, now we worry about a couple different things. So that could be the joint is unstable, so we worry about the passive stabilizers like the capsule or the ligaments, and then of course the active stabilizers that help out are going to be the muscles. So do they have some neuromuscular control issues if it's a giving way sensation related to muscles, or is it shifting in and out of place because the passive stabilizers of the joint are too lax or unstable, right? Okay. So after we determine the mechanism of injury, then we try to figure out, more about the pain. So where is it at, the type, and then the amount or the level, and then things that make it better or worse. So McGill is a study group from the university in Canada. So their pain description is famous in the 70s and 80s and still today. So they have these kind of set guidelines and these survey questions that the patient typically fills out beforehand, which saves you time. So it kind of describes it as something superficial or deep, right? That's what they mean by external or internal. And then we have these different categories, and then they can mark on the body the anterior or posterior side. Okay, so further assessment, the easiest, the one we typically use is that 11-point pain scale, so 0 to 10, you got 11 points there. Sometimes there's a visual analog where they can rank it on a category. So here we see the visual and the numerical pain scales of this 11-point scale, 0 to 10, and then it has categories on each side, right? So mild, moderate, severe, 10 being the worst pain they ever felt in their life. Usually when I'm trying to put it in the context, I'll ask the patient, have you ever broken a bone? Or before this, what was the worst pain you ever felt? And then that way you can kind of gauge it, versus their current condition. So if someone's broken a bone, then they know what severe pain is like. And then for younger children or people who have trouble with communication, we can use the smiley face. Okay, so another goal in our history portion of the exam, we're trying to figure out what is changing the symptoms, right? What is making it better or worse? In general, let's say you have a shoulder injury. When people rest, so they remove themselves from their activity and they do some therapeutic exercise and modalities, you should tend to improve over time. So over 2 weeks, if they're not improving, then usually I worry about them. So are they ignoring the indication of rest? So are they still going back to their sport and activities? Are they not following directions? Are they not completing their exercises? Or are they doing too much? Right? That could be a problem as well. Then, do they need to refer? Do they need surgery? Then you got to figure out, like kind of next step of why they're not improving. Then of course, day pain, night pain, how does it change throughout the course of the day, especially with tendinopathies? And then their activity level with overuse injuries is important. So if we think about volleyball athletes, we have a high percentage of rotator cuff tendinopathies due to the workload. So if we think about overuse injury classification, and we use rotator cuff as an example, with a minor injury, like a grade 1 tendinopathy, they'll typically only complain of pain after activity. So let's say they're an elite athlete and they're going through like a preseason training protocol. Let's say they go through like a week's of practice, and at the end of the day, they just have a little bit of pain and discomfort. These patients typically don't come in. It's like, okay, I just worked out really hard today. I've got some muscle soreness. It's not that big a deal. Here's where people tend to come in and get treatment. It's when their performance or their activity level starts to decline. So it's either their accuracy, or if the pain starts to increase to during the end of practices, or it extends from during to after. So we've got an increase in the amount of symptoms or the length of the symptoms they're experiencing, plus this decrease in performance with a grade 2 overuse injury or tendinopathy. This is when they want to get treated, right? Because it's affecting their performance. And then if it's not being treated or managed appropriately, it can progress to a grade 3 overuse injury or tendinopathy, where they're having complete loss in their participation ability. So it's hurting all day. Okay, so that table is important. Make sure you guys understand that table and know it, especially to be able to answer questions when we move on through the individual joints. So chapters 15, 16, and 17. Okay, so after we kind of wrap up the current injury during the history portion, we also have to think about previous injuries or things that are affecting it. So injuries to the same or opposite side, the ipsi and contralateral joints or limbs. And then, there's symptom description. So things that are causing weakness or numbness. Okay. Another important thing to consider are current, recent training or activity level changes. So let's say they're typically a swimmer and they're ramping up their activity, and let's say now they want to start training in the ocean, or they're training for like a rough water swim. So going from a pool to the ocean, of course, with the tide and the different conditions, that could cause some changes to the motion that they're doing, which could be enough to cause tendinopathies. Or if they're trying to go from like a sprinter to like more distance, that can affect their pain levels. Or if they've recently been detraining, so if they haven't been training as much and now they're trying to pick it back up and they're increasing the workload too much and too soon, like all those things can lead to overuse injuries. Always important to remember what kind of current or recent treatments they've had or other providers that they've seen, so that kind of bleeds into this next point. So if you're treating them at your clinic, are they seeing other providers, and what do those treatments entail? You don't want them doing too much. And then any medications that they're taking, that's also important. Family history, allergies, general medical conditions, those are always important to denote as well. Okay, so that kind of wraps up history. Transitioning to the next part, our observation. Right, so first part of the exam is always history, then we do observation. So always keep that hopes in your mind when you're thinking about clinical scenarios that we're going to talk about later in the semester. So of course we have two sides, so we can always assess bilaterally. So if we saw a patient presenting with this, and they had an acute mechanism, we'd be worried about glenohumeral dislocations. This is typically what it looks like, where we can see this outline and divot within the deltoid. And if they're holding or carrying it in a particular way, regardless if it's an acute or chronic condition, how they're holding it can tell you, what the condition is. Okay, so when we're observing the area, we want to make sure that we're checking for gross deformity. So that would be things like an obvious fracture or a dislocation of the joint and the bones that are making up the joints. And then our next one down, any types of swelling or effusion. So we'll talk about these terms a little bit. Edema would be kind of more widespread, kind of like you can see this hand that's really swollen. And then effusion would be specific to just swelling inside of a joint capsule. And then a hematoma, remember heme refers to blood. So if an injury that is swelling and blood related. And then we want to observe for bilateral symmetry, so making sure the left and right sides are symmetrical. When might they be off? So obviously limb dominance might play a part in that, or if they've had a previous fracture or dislocation to either the ipsi or contralateral side. So those things are important to denote why symmetry might be off between the dominant and non-dominant limbs, as well as the injured versus uninjured side. And then skin color, temperature, and condition. Of course, we're worried about the signs of inflammation, so red, hot, swollen. So all those things are important to denote. Additionally, previous injuries or surgeries that required scars or resulted in trauma or calluses. And then, of course, infection, if it's purulent or filled with pus. If the wound smells bad, if there's signs of infection like redness or streaks that are red that are coming back up towards the body, those are red flag signs that the infection could be spreading. And then, of course, if we continue this idea of edema, remember, return of fluid from the periphery back to the body is accomplished through the venous system and the lymphatic system. So remember, 10 to 15% of fluid returns through the lymphatic system. And remember, that relies on a pressure gradient. So the arterial blood supply, it's got higher pressure than the capillary beds, and then the venous and lymphatic systems. So that pressure difference is what allows the fluid to keep moving. When an area becomes stagnant or injured, let's say you have a really bad injury and all the proteins inside of the cells spill out and you get more viscous fluid, or there's a thickening of the fluid, the area becomes stagnant, which means the flow stops. And then you could end up with pitting edema, which we see in this picture here, where a swollen area, you push your finger into it and the divot remains. Right, so that's a red flag sign that the return of fluid is being impeded. Okay. So when we observe injuries, it's important to, number one, think about the area and all the anatomical structures. So if we look at this, right, if this is someone's left shoulder, you have to start by thinking, what are the bones? So we have the clavicle, the acromion, the spine of the scapula. The first rib is deep to it. And then you got to think about the joints, the muscles, if it's injured, like why is something poking on the skin? So this one's actually, I believe, a clavicle fracture. This one we can see, if you start with the SC joints, that's pretty normal, and the clavicles look pretty normal, and the ACs look pretty normal. And then there's kind of a step off here. So this is a picture of a glenohumeral dislocation. So you can see that kind of divot forming there. Here we see that same divot. So this is a good example of anterior and inferior glenohumeral dislocation. That's the most common direction. And you can see the carrying of the body part to support the injured limb. More distally, we see an elbow dislocation. So this is a posterior elbow dislocation. So you can see the ulna is more prominent. So when we describe elbow dislocations as posterior, we're referring to the ulna being driven posteriorly relative to the humerus. Okay, this one's not an injury, but rather just a clinical finding that contributes to injuries. So this is scapular winging. So you can see a prominent medial border. And we talked a little bit about infections already, but here you can see a line has been drawn around this reddened area. And if the patient comes back then the next day and the redness is outside of the circle, then you know that the infection is spreading. And that's a major red flag. I gotta get to the hospital immediately to get treatment. Okay, so that's observation, right? We do history and then observation. And the next thing is always gonna be palpation. So now we're gonna use our hands and fingers to detect the surface anatomy. So again, remember, step one is understanding what's normal and then being able to determine what's abnormal. We have two sides, so you can always feel that normal or that baseline measure on the uninjured side. And then we have to figure out the different anatomical structures within that superficial layers of the anatomy. So people are either one of two ways when they first start out. I always liken it to when people learn to drive. Either they barely push the gas pedal or they just mash it in all the way. So when you're learning to palpate, remember, you always want to start with very light, gradual pressure, and then you build up. So you start very superficially in the tissues, and then you kind of work your way down, increasing the pressure because of the likelihood that it's going to cause pain. And that's just something that comes with experience. Okay, so again, like I mentioned, we always have to start with what's normal. So if we understand how these different layers feel, and each joint's going to be a little bit different, right? So skin, subcutaneous fat, so the fat that's just below the skin. Bone typically feels hard, tendon and ligaments are more firm, and then muscle is the softest, right? And typically we'll describe a muscle as being striated. So when you palpate along muscle fibers, has that kind of like rope-like kind of lines that you can feel because the muscles are striated, versus a tendon, which feels like just like a dense solid object. Of course, then we can figure out the tissues that are causing abnormal sensations. So point tenderness, which means I push on something and it hurts, which generates the pain. Feeling for fluid, effusion or swelling or edema. Trigger points, which are in a muscle belly, so within the muscle fibers. So normally it's relatively smooth and you can palpate through the muscle. A trigger point would be you come to like a hypersensitive nodule or a thickened area in a muscle belly, and that causes referred pain. So a trigger point is the actual nodule, and that could result in referred pain. So there's parts where, like, if you push on someone's upper trap, they might feel the pain in the center of their forehead, and it causes like a headache type sensation. So that's an example of referred pain. Crepitus would be that crunchy, gravelly sensation. Then, of course, symmetry, right? If they're not symmetrical between injured and uninjured sides. Okay. Then on to our evaluative tests. So history, observation, palpation. Now we start to do our active, passive, and resisted range of motion. I tend to describe them in this order: active, passive, and then resisted, because of the stress that it places upon the body. I think the textbook kind of lists some, resistive and passive trade place in a lot of places, but this is the way I was trained, so this is the way I always do it. Because resisted, the greatest amount of force is being applied, so you have the greatest chance to cause pain to the patient. So I typically save that one for last. Okay, so remember, active range of motion is the person is using their muscles to create changes in angles at a joint. Passively, the clinician is moving the joint passively through its range. And then resisted is we're applying additional force above active. Within that resisted, we have manual muscle testing, which we'll talk about, volumetric, limb girth, and then some neurological stuff. So here's our breakdown of our evaluative tests. So for range of motion, we mentioned we do active and passive, and then we're going to measure those with a goniometer. If you've already had XPhys lab, you probably had some experience with goniometers, and that's good. So remember, it's a fulcrum. It measures 180 degrees, and we use that to determine their active and passive range of motion. So of course, actively, we're trying to get a precise measurement of how the muscles are moving it through its range, and then passively, the clinician has to forcefully move it to its end range. So we're looking for, with the goni, what's the maximal position they can get to. So here you can see the patient's at like 165 degrees of shoulder flexion. But if the clinician was doing it, then they'd have to passively move it. And that gets tricky to measure passive range of motion because you're using your hands and the goni at the same time. Okay, and then we're always comparing bilaterally, or if there's some reason why you wouldn't. So either they had a previous injury, or if they're like a uni-limb dominant athlete, we would expect changes, like baseball pitchers and outside hitters in volleyball. They'll typically have increased external rotation on their dominant arm. and decreased internal rotation. We'll talk about that in the shoulder chapter. And then another thing we're looking for, so aside from that total number in degrees, like 180 degrees of shoulder flexion is normal, we also want to assess, does it hurt when they do it? Right? So if someone's unable to perform active range of motion, do you have reason to suspect a fracture? So if they have an acute traumatic event, we might have to stop and refer at that point. Or mechanical limits, right? So if the range of motion is limited for a particular reason, is it because of the bones? Is it because of the capsule or the ligament, or changes to the tissues? That's what we're trying to assess with those mechanical limits. Okay, so remember, actively, it's the contractile tissues, so how much the muscles can move it. Kind of like a sub part of that is if they're having trouble, let's say your patient, instead of being able to flex 180 degrees, let's say they could only do like 70, but if you help them kind of lift and elevate the arm, that's an example of active assisted. So we don't really use too much of that in our class. And then passive, we're trying to stretch the soft tissues, and we call that the infield. So at the end of the range of motion, so let's say at the end of elbow extension, right? You extend and lock out your elbow all the way passively for your patient. That should have a particular feeling or sensation when you apply overpressure at the end of their passive range of motion. So if it's stretching of soft tissues, there's a particular infield, and we'll talk about what those different infields are coming up. Then of course resisted, we're adding additional force above gravity. Okay, so in passive range of motion, you're taking your patient to their total in range, and you're measuring it with the goni. So you get 0 degrees of elbow extension. Right? And then if you continue to apply overpressure, that tells you what the joint feels like at in range of motion. We call those infields. So normally the joint has 3 options. Right? So something that's soft. Imagine you flex your patient's elbow and you're pushing into overpressure into elbow flexion. You're bumping into the bicep, so that tends to feel soft, right? So at the infield of elbow flexion, that's soft. With horizontal adduction, you're bumping into the pec major, so that might feel soft as well. Things that are the muscle, the capsule, or the ligament tend to feel firm. So let's say if someone does maximal elbow flexion, but they feel it in the tricep tendon, then that could be stretching of the tendon, right? Versus if they feel a soft infield, it could be in the bicep. A good example of a firm endpoint is finger extension. So if you just pull your fingers back into extension all the way, and then once that range of motion is gone and you apply overpressure, right, that finger extension, you should feel the capsule and ligaments stretching. And then a hard infield is bone on bone, right? So we'll go back to the example of elbow extension. When you apply overpressure in elbow extension, you get the olecranon popping into the olecranon fossa. So that has a hard infield, right? Because it's bone on bone contact. Okay, so make sure you understand these passive range of motion infields, table 1-5. Make sure you know and understand at each joint what those normal infields are. Most of the joints in the body, it's going to be firm. Right? So almost all the time, things are firm. So it's easy to remember the exceptions, right? So soft and hard occur less frequently. Okay. So in the textbook, it goes from table 1-5 to 1-4 to understand the normal and the abnormal. But what would make an infield different? So if we think about what's normal first, right? Always remember what's normal. Elbow extension is always hard, right? Because when I lock out my elbow, the olecranon and the olecranon fossa contact. That's bone on bone, that should be hard. If you get a boggy infield or something that's abnormally soft, then we assume that there's some swelling, right? If it's firm, we might think like the muscles are spasmed. So if I try to extend my elbow all the way and it doesn't move, maybe there's a spasm in the bicep, right? Because that would stop me from extending. So it'd be the opposite side of the joint. And then an abnormal hard infill, maybe there's a bony growth, exostosis, or a loose bony fragment in the joint. So something that's creating an abnormal hard infill when it should normally be firm or soft. Okay, and then the last one that they don't kind of mention here, but anytime we're assessing a ligament at a passive range of motion or for an infill, if it's completely torn, then the ligament or capsule is not there to stabilize it. Okay. So thinking about trying to combine these ideas of active and passive range of motion, if someone's limited, but they have normal passive, right? So let's say you can flex your patient's shoulder up to 180, right? So passively you can move it. But when you ask them to actively flex their shoulder, let's say they're limited and they can only do 80 degrees and they say it's painful, right? So if actively it hurts, but you know physiologically they should be able to get to it, then we can assume it's probably the muscles that are involved, right? Versus if both are limited, so if, let's say they were both 80 degrees, then it's a little bit harder to tell, right? It could be the muscles, it could be ligaments, it could be bone. So this is kind of a little tip or trick, right? If they have full available range of motion, if the bones can move through the range of motion, but the patient can't do it on their own, then we can try to think about the muscles as being the thing limiting them. Versus conversely, the other rationale would be like if they don't have normal motion at all, is it something within the shape of the bones, or is it an injury that's occurred to the capsule or the ligaments or the bones? Okay, so now we did active and passive. Let's think about assessing muscle strength. So that's going to be our resisted range of motion. Remember that it occurs through the cardinal plane. So you have to remember the three cardinal planes: sagittal, frontal, and transverse. Those are the ones I tend to use. I know some people use coronal and frontal interchangeably. That's fine. I tend to say sagittal, frontal, and transverse. So you have to remember the muscles that are acting in each plane. So when we test resisted range of motion in clinolhumeral abduction, right? So the patient's arm is at the side and they abduct all the way up, and then they adduct all the way down. When we assess through an entire range with added force, that's resisted range of motion, right? Through the entire cardinal point. Versus if we want to tease out, well, was it the deltoid or was it the supraspinatus? Those are individual manual muscle tests, right? So typically, isometric brake tests or a manual muscle test, you're just testing in the mid-range, but there's some exceptions. When we do the shoulder lab, we'll do some really full manual muscle testing of the shoulder muscles because there are so many. Even though there's only 3 planes, you got a lot of muscles going on. So we'll see a good example of how to do thorough manual muscle testing when we get to the shoulder chapter. Okay, so how do we do it? So we're trying to determine how well the muscles can produce torque or force. And so when we think about the things that cause injury, you have to consider a lot of factors within the patient, right? So are you testing their dominant side? Do they have a reason to be imbalanced? So I use the example of baseball pitchers, right? They tend to have changes in their strength and range of motion based on their sport participation. Previous injuries that may have caused atrophy, and so that could be either the muscle or the nerve, which makes the muscle shrink in size. And then we have to think about our technique. Okay, so if we want to test and isolate individual muscles, we have to understand that if you do like a resisted elbow flexion, there's no way of truly determining or turning off the brachialis versus the bicep, right? Both those muscles flex the elbow. So you can't do pure isolation, but you can position the muscles in a way to either shorten or lengthen them. If you've had biomechanics, you probably remember the muscle length tension curve, which says muscle's weakest when it's completely shortened or completely stretched. So we can use that to our advantage to try to position the body in certain ways to to focus more force onto certain muscles. This will make more sense once we go through the labs. Okay, so here we see a good example of resisted elbow flexion. So step one, right, we have to stabilize, right? So if we're going to do elbow flexion, we have to put one hand on the humerus. That's this clinician's left hand is stabilizing near the axis of rotation. And then you're going to provide manual resistance. So if we want to test elbow flexion as a resisted range of motion, we'd start lengthened, right? So the elbow would have to be extended, right? So if we're going to test resisted range of motion through the entire cardinal plane for elbow flexion, you start in full extension. That way they can concentrically bring the arm all the way up and then eccentrically all the way down, okay? So these two, concentric and eccentric, is when you're using your resisted range of motion. If you're trying to isolate just the bicep, then we would do a break test, which is our manual muscle test. And you can see this 90 degrees of elbow flexion is for two joint muscles, okay? So if we're going to do a break test just for the bicep, we would put them in their mid-range and say, hold it here, don't let it push you down. So you're pushing down while the patient is trying to resist that and hold that isometric position. Okay, and then we have to grade them. So the trick with any table is saying, what's the thing I've already done before? And so, sorry, this is a little bit of review. So we talked through this already. So remember, resisted range of motion, RROM, is through the entire cardinal plane, sagittal, frontal, and transverse. And then we kind of talked through this already, right? So for resisted range of motion, you always start lengthened. So the example I gave, we're going to test the elbow flexors. You start in extension, and then you test the concentric phase first. And then in the lowering part, the muscle is lengthening, but still developing tension. So that's eccentric. Okay, this is kind of where I left off. We did the break test in the mid-range, and then we'll do a grading. So here's a grading I was kind of talking about. So if you've already done your active range of motion, remember, if I'm just standing here and I'm doing elbow flexion up and down, there's resistance that comes in the form of gravity, right? So active range of motion, the resistance is 9.8 meters per second, right? The acceleration due to gravity. So if someone can do full active range of motion against gravity, our muscle strength is a 3 out of 5, which we call fair. So anything above that, they're stronger, or they can resist more force than gravity provides. So you can see a 4 and a 5, so moderate strength, and then full strength, 5 out of 5. So let's say you're a patient, you ask them to do active range of motion, and let's say they can only flex the elbow to like 30 to 40 degrees before they say like, oh, it hurts too much, I can't flex it up all the way. Then we'd know they're below a 3 out of 5, in which case it's poor or trace, right? So poor would mean full range of motion without gravity. So instead of seated doing elbow flexion, if they laid on their side and now they're doing elbow flexion, you've removed gravity, right? So if they can do full range of motion without gravity, 2 out of 5. If they can cause a muscle to contract, right? If the muscle can develop tension but they can't make it move, 1 out of 5. And if there is no contraction, 0. So remember, if the muscle doesn't produce tension at all, it's either because there's a muscle tear or the tendon ruptured, right? So there's an acute injury, or the nerve is not sending the signal. So then you have to figure out, is it a central nervous system, brain and spinal cord issue, or is it in the periphery where the peripheral nerve is not sending a signal to the neuromuscular junction to cause a contraction? Okay, so I know we've been talking a lot about MMTs and resisted range of motion, but some of the finer points are, remember to always maintain consistent pressure, and then make sure that the direction you're pushing is for the muscle or the cardinal plane you're testing. So if you start pushing off in an abnormal or an off-center direction, then the patient's just going to resist and push against that force. Always describe things in great detail before you actually perform them on your patient. And sometimes you're not going to be able to break them during the eccentric phase. So you either have to let them know, like, let me win and slowly control it down in a smooth, fluid pattern, or just try to, let the patient know that sometimes they're stronger than you. Okay, so that wraps up our evaluative part for active, passive, resistant range of motion. Make sure you're reading those sections carefully in your textbook and get those ideas solidified before we move on, because we're going to have them in each subsequent chapter when we talk about the joints. Then we have our volumetric and girth measurements. So we don't typically use these in the upper extremity. Mainly they're used in the lower. You can see the examples here the textbook gives. So we're trying to monitor the amount of swelling. So you can compare bilaterally or over time to see how this swollen ankle displaces water. Right? So it's about fluid displacement due to swelling. And then a girth measurement, you're trying to determine either atrophy, hypertrophy, or changes in the size of a muscle or a joint. Okay, then our neurological testing. So we're going to have an entire lecture dedicated to the upper quarter screen. So we'll talk about these a bit later. So German tones, myotones, and our reflexes. And then we have our selective tissue tests or special tests. So these are part of our differential diagnosis where you're trying to rule in or rule out very specific conditions. So if someone has shoulder pain, is it bicep tendinopathy or a labral tear? And so you're going to use a battery of tests to determine that. Okay. When a special test is related to a ligament, so like in the glenohumeral joint, we often have laxity that leads to subluxations and dislocations. It's very common. And so when we test those ligaments and capsules of the glenohumeral joint, we're trying to feel those infills we already talked about. Right? So remember, normal is firm. There's no laxity. Laxity is like a stretching sensation. And then for certain special tests in the glenohumeral joint that we're going to learn, if you have a soft or an empty infield, or there's increased laxity, or if it feels empty and it feels like it's apprehensive, then we worry about the joint being unstable. Okay, so these will make more sense as we go through our special tests, but that's basically how ligaments feel when you stretch them. Okay, so that's going to wrap up the end of chapter 1. Hope you guys enjoyed it, and I'll see you guys for the next video. Take care.